So it's just introducing Prof. Kim Dalziel from the University of Melbourne and Murdoch Children's Research Institute. She's heading up a large program of work doing a multi-instrument comparison study in health-related quality of life measures for children. She also has specialist expertise in economic evaluation and modelling, child health policy, vulnerability, equity, and the use of health services and economic evaluations alongside clinical trials. Renee Jones is one of her PhD students at the Health Economics Unit at the University of Melbourne, and she's been working on this project with Prof. Kim Dalziel. So I'll hand over to them to present their findings. Thank you.
Thanks so much for having us. It's just so nice to be here. So we're assuming we can. Yeah, good. So firstly, we just wanted to acknowledge the traditional custodians of the land on which the research was conducted, which is the Wurundjeri people in Melbourne, Australia, and just recognise them as and their role as traditional owners of the land on which the research was conducted. So I came to this research program predominantly from an interest in economic evaluation, and when we were doing the economic evaluations in child health, we had so few measures to work with around quality of life. So this was sort of a complementary program that we designed to try and make a methodological contribution that could help our health economic evaluation work. So I'll briefly go through, follow this sequence today. We'll give you some background and objectives, go through who were the sample that we recruited, the types of analyses we conducted, and it's a really large data set. So it's turned out that we've been able to answer way more questions than we even initially set out to answer. So we'll show you just how we're answering a few of those questions in the data set, and then give you just a couple of results, conclusions. We're hoping we'll have some good time for discussion as well. So here's our research team, and it's ended up a little bit of a cast of thousands, but these are, you might have heard of some of these names. Professor Nancy Devlin, Brendan Mulhern are working with us, and paediatrician Harriet Hiscock, and a whole heap of people that do most of the work, researchers and PhD students working on the study. We are funded by an Australian government grant and also by a supplementary Euroqual Research Foundation grant. And then a number of our members have received previous funding from Euroqual before, so we'd like to acknowledge that as a conflict. So in terms of the background to our project, what we wanted, the reason for the focus on children is because children, particularly really early childhood, is an area where healthcare spending is higher. So we have high healthcare spending early, so that's interesting from a health economics perspective. And also it's a place where we lay down trajectories for a healthy adult life as well in childhood. So it's also interesting from a human capital perspective, like that we're making early investments for future health and development. So there were a growing number of preference-weighted quality of life measures available, even in childhood, but we didn't know very much about how they performed and which ones were best and which ones should we choose for which types of children. And particularly once we got to these children under the age of 5, which is where a lot of the healthcare investment happens, we really had very little to go on at all in terms of what we could use for our economic evaluations. And this limited our ability to conduct good quality economic evaluations and to inform those priority setting decisions that would result from our cost effectiveness evidence. And so, for example, we looked at some of our Australian evidence around, we usually would use cost effectiveness evidence to decide when we funded a new medicine. So we had a look at our funding decisions around medicines, and for those, when we looked at what quality of life was included in the cost effectiveness for the new medicine, around a quarter of them were actually using adult quality of life measures. And we're like, it was a big limitation, but that was being used to inform current decisions about medicines to fund in Australia by the government. So it showed us there was a really important gap there that had practical implications. So we wanted to know which instrument should we be using to measure child quality of life, in which setting and for which types of children. All right, so I think I'll pass to Renee here.
So to address this sort of research gap, we conducted the Australian Pediatric Multi-Instrument Comparison Study, and we collected 3 key samples of children and data on almost 7,000 children. So we included children aged 2 to 18 years old. We had a sample of children that we recruited through a tertiary paediatric hospital in Melbourne, which was really to get a sample of children that were quite unwell, to look at how health-related quality of life instruments performed in those kids. Then we had a population of just over 1,800 children that were a general population of children, and they were recruited through an online panel. And then finally, we had a third key sample, which was just over 3,800 children, where we included 11 different health conditions. So we had children who represented one of these 11 health conditions, and we recruited about 400 kids to each of those, give or take, to each of those health conditions, so we could look in those health conditions of interest how these different instruments were performing. So participants completed an initial survey where we asked them lots of questions about their demographics. We asked them some non-health related quality of life questions, and we asked them to complete a range of health related quality of life instruments. Then either 4 weeks or for a smaller subset 2 days later, we asked them to repeat those health related quality of life instruments. And we also asked them if they'd had any change in health since they'd completed the initial survey. Children aged 7 years or older, we asked their caregivers if they felt that their child was able to answer some questions about their health and wellbeing. So if their caregiver said yes, they are, then the child self-reported the health-related quality of life instruments. If they said no, or if the child was younger than 7, then the caregiver proxy reported the health-related quality of life instruments. It was quite a large survey, so after a bit of feedback from piloting, we decided on having a core set of health-related quality of life instruments. So all of the participants received some commonly used instruments called the EQ-HWB3L, the EQ-HWB5L, the CHU9D and the PEDS-QL. And then a select few were randomised to also receive one of these additional instruments, so the AQL60, the PROMIS 25 and the HUI. The children who were part of this online panel condition group sample, one of those 11 conditions, we also asked them to complete a condition-specific instrument. So the asthma kids received the PEDS-QL asthma module, for example. So just a little bit on some overview of the characteristics. The mean age of children was about 10. About 42% had some sort of chronic condition or disability, which is validated also by screening positive on the what's called the Special Healthcare Needs Screener, which is a screening tool used to indicate if a child has a chronic or ongoing health condition. The caregivers' mean age was about 40. 38% had a bachelor degree or higher, so a slightly higher level of education to our general public. And it could be any caregiver who could complete it, so it could be grandparents, it could be older siblings, but 96% were parents, so largely it was parents who were completing. As part of the Pediatric Multi-Instrument Comparison Study, we did a body of work looking at how we should assess the psychometric performance of these instruments. And so we generated a psychometric analysis guide, which you can access through the QR code, or we can send a link around as well, which is part of our technical methods paper. So you might have to jump down to section 14, but you'll find it there. And it just runs through how we defined how we would measure different things like acceptability, response distributions, test-retest reliability, known group validity, convergent validity, and responsiveness. So we came up with a lot of decisions that we had to make around what thresholds would we use to say, yep, this instrument performs okay on test-retest reliability, or no, it doesn't. And we had some wonderful experts review that for us. Thanks, Judy. Yeah. That was a huge amount of work for us, and we really hope that that can then inform our consistent approach going forward for lots of these results. So, yeah.
All right, so today what we're going to go through is just, we've ended up with about 20 papers that we think we can write from this data set, but we're just going to go through a couple now. So the first one is looking at how the instruments perform for children aged 5 to 18. The second one we'll show you is a particular sample of children with mental health problems and how the different instruments perform there. Thirdly, we'll show you asthma, sleep problems and epilepsy, which were 3 out of our 9 conditions that we targeted. There's no particular reason we're showing you those other than they're just the first 3 that we've looked at. Then we'll show you some of the results from the younger children, so those children in the 2 to 4-year-old age group. And then very briefly, we've got this new instrument called the EQ-HWB, which is it's like we use that to measure the quality of life of the parents of the children. So we'll also show you the results of the parents. So we'll run through these. We've just got 2 or 3 slides on each and show you just a few of the results that we're coming up with. So I think you're starting off here.
Yes, so first cab off the rank is the children aged 5 to 18 years. So we were really interested at looking at how some of the commonly used instruments, so the 3L, 5L, the CHU9D, the PEDS-QL, the HUE and the AQOL performed compared to one another in those children aged 5 to 18. So we looked at the psychometric performance of those instruments and I'll take you through the results, but we look at ceiling and floor effects, test-retest reliability, known group validity, responsiveness, and we also have had a look at some different subgroups that we think might be important. So the first thing I thought I'd show you is the ceiling effects. So this is the proportion, this is the number and the percentage of participants who select no problems or the equivalent, so the lowest severity level on all of the instrument items. So if it was the EQ-5D-Y, they'd tick no problems for the 5 questions. So what we can see here is that the PEDS-QL, the CHU9D, the AQOL and the HUE have relatively low ceiling effect issues, also likely because they have a larger number of instrument items. But you can see here that the EQ-5D-Y, 3L and 5L have a higher percentage who are demonstrating a ceiling effect. But we've used a threshold of 15% to give us an indicator of that might be a ceiling effect issue. And so the EQ-5D-Y, 3L is showing a ceiling effect issue there. And I should say, sorry, that this is just participants, this is just children who have screened as having a special healthcare need, so children who have a chronic or ongoing condition where we might expect that they might have a problem in one of their health-related quality of life domains. We also had a look at known group validity, so we looked at the difference in total or level sum score between the group of children who didn't have a special healthcare need and who did have a special healthcare need. And what you can see here is that all of the instruments were able to differentiate between those 2 groups with large effect sizes. So that's a tick for all of them. I haven't got it on the slide, but we did have a look at a range of other known groups and what we found that consistently all of the instruments were able to differentiate between those groups, and that was consistent across different child age groups and whether it was self-reported or proxy reported. So another thing we had a look at was test-retest reliability. So, and we only included the participants who'd completed the follow-up survey at the shorter 2-day interval, because that's where we were interested in testing test-retest reliability. And what we can see is that their responses at 2 days are pretty consistent with their initial responses. Some of the instruments have higher agreement, that the CHU9D shows slightly lower agreement, and that's consistent across those subgroups. So slightly, I guess, less agreement for test-retest reliability, but it still sat above our threshold of what we would consider giving a tick, I guess. And finally, we looked at responsiveness. So we, for children who said they had much better health at the follow-up survey or much worse health at the follow-up survey compared to the initial survey, we looked to see if the total or level sum scores were different in the direction that we would expect. And what we found was that the PEDS-QL was able to pick up on differences for worsening health. So their total score dropped for worsening health, but it wasn't able to pick up on improvements in health. The EQ-5D, Y3L, 5L, and CHU-9D were able to pick up on changes in health in both those directions. And the AQL60 and the HWB3, our sample size was a bit too small to be able to draw any robust conclusions there. I'll wrap things up pretty quickly because I know I've been speaking for a while, but when we have a look at all of those things together, what we see is that the EQ-5D-Y5L and the CHU-9D met our sort of criteria for acceptability across all those different thresholds. There was some slight differences in child age, so when we looked at it by child age and report type, particularly for test-retest and responsiveness. So something important for us to consider, that if you're only doing self-report, it might be important to consider those results.
No worries. So the second question we're going to show you just briefly is the children with mental health issues. So it's quite a similar format to what Renee's just been through. We'll look at those instruments. We had groups of children with internalising and externalising mental health challenges. So we had one group of children with ADHD who were aged between 4 and 18, and another group of children with anxiety and depression between age 7 and 18. And then we looked at those same types of tests. So in terms of ceiling effect, that's the line there, the 15%, where we would say if it's above the line, if there's, then it's starting to indicate a problem, like we're wanting the instrument to detect problems, and that's an indication that the instrument's not detecting problems in that child. So the main issues arise, I think I've got here. For the ADHD sample, we see a ceiling effect for the EQ-5DY. And then over here for males, we see a ceiling effect for the EQ-5DY as well. So, and they were the biggest two issues, I guess, with ceiling effect. And then for known group validity, what we've done here is we've looked at quite a few different ways of looking at known group validity. So we had some measures called the SWAN, the SDQ, and the RCADS, which were all mental health type measures. So we are able to know on those measures which children had problems with their mental health. And also the children with the special healthcare needs. So this is the proportion of those four analyses that showed good known group validity. So a number of them are showing good known group validity. Most of our our instruments are showing good known group validity across all those 4 tests that we ran. Highlight it. The exceptions are really that I'd point out. We've got some places where we didn't have enough data, which was the 4 to 6 year olds. So that's not enough in the ADHD sample to run those tests. And I guess we're seeing lower amount of known group validity in the green and the blue, which is the AQL and the HWB. So they're not performing as strongly in picking up the mental health problems that we know are there on other instruments. In terms of test-retest reliability, once again, for our AQL and HWB in the 4 to 6 year olds, for the 4 to 6 year olds and the AQL and HWB, we just didn't have enough data to really be able to draw good conclusions because they were in those randomised extra instrument groups. So here, the line where we would consider it to be acceptable is above 60%. So we're kind of hitting a little bit more issues here with test-retest reliability in the mental health samples. The ones that are performing the best, highlighted are here. So we've got the EQ-5D, Y3L, and the CHU-9D in the anxiety and depression sample, and those older children, 13 to 18 years of age, are where we had the best evidence of test-retest reliability. And a number of the samples just dropping a little bit below that. This one's sort of just hitting the line, which is the PEDS-QL and the EQ-5D, Y5L. And over here, the same with the CHU-9D as well for males and the 7 to 12 year olds. So not all of them, but a few of the samples were just hitting acceptable test-retest reliability. And then responsiveness, what we've got is the combined sample. The instruments that performed well were the PEDS-QL, EQ-5DY3L, and CHE9D. Once we drop into some of these other samples, there's a number of the samples where we didn't have enough children who were changing health to be able to assess it. But I guess what I would point out is perhaps across these other samples, the yellow is performing quite well, which is the CHE9D for females and the older children. And then I guess it's the EQ-5DY3L performing well in males. So there's something with mental health that's a little bit tricky, like something quite different between the girls and the boys, and they're finding it harder to pick things up and to report reliably from one time point to the next time point. Yeah. And this is just an overview. So what this graph shows is the different instruments are a different colour, and if they were further out towards the outside of this, is it a hexagon? No, septagon. If the lines were further out to the outside, it would indicate better performance. So what we're seeing here is that different instruments have different strengths. So I'd point out, say for known group validity, you've got the yellow and green, which is the two EQ-5DYs that have really good, strong performance. Whereas for down at responsiveness, the CHE9D has a bit stronger performance. So they kind of have different strengths and different weaknesses. But all four of them were easy to complete. And yeah, I think I've got an overview slide next. So I guess this is our overview. I'm sorry, I've got a... I think the main takeaway is just different strengths and different weaknesses. So it depends what you want that instrument to achieve. I think the graphs that are further towards the outside is that CHE9D, perhaps the EQ-5DY3L and the PEDS-QL are all the ones that sort of cluster a bit closer towards the outside, meaning they perform better. I think it's back to Renee now. Yeah.
So our next research question was to look at the performance in children with asthma, sleep problems, and epilepsy. So these are three of the conditions that made up that condition-specific sample, where we were trying to get a couple of hundred of children from each of those conditions. And really, I think we chose these conditions. They were the first to complete, some of the first to complete recruitment. So we had the data available, but also they represent some different types of health conditions. So asthma is quite an episodic condition. Epilepsy, from some recent data we looked at in Australia, had some of the highest health-related quality of life decrements. So interested to see how across some of these different conditions that have different sort of clinical attributes, how they might perform. So just looking at the EQ-5DY3L, 5L, CHE9D and PEDS-QL here, and largely in children aged 5 to 18, except for sleep problems, which is 5 to 16. And looking at some of the psychometric attributes we've already run through. So I'll jump straight into the results. So the first one is looking at the ceiling effect issues. So this is in the cohort of children who we determined as being slightly more severe based on their responses to that condition-specific questionnaire. So for the asthma kids, it was the PEDS-QL asthma module. And so we looked at just the more severe kids who we would be expecting to report some health problems. And what we see really using that 15% threshold again is that the EQ-5DY3L and 5L in the asthma cohort is displaying some ceiling effect issues there. The next thing I wanted to go through was the test-retest reliability results. So what we see here is that in children with epilepsy, so I'll start off with the epilepsy sample, all of the instruments showed sort of acceptable test-retest reliability except for the PEDS-QL. In the sleep problems sample, all of the instruments except for the EQ-5DY3L showed acceptable test-retest reliability. And then in the asthma sample, it was just the EQ-5DY 5L and a CHU9D that sort of met that acceptability threshold for retest reliability. We looked at a couple of different known groups here. So the first thing that we wanted to look at was, are the instruments able to differentiate between a general population of well children and children from those health condition samples? So we looked at general population. So for the epilepsy sample, we looked at children from the general population sample and children from the epilepsy sample, and we were interested to see if the instruments, in terms of total or level sum score, were able to differentiate between those two groups. And all of the instruments for all of the conditions were able to differentiate between the general population of well children and children from that health condition sample, with large effect sizes as well. The next two known groups we looked at were severity. So we're interested within each condition, do children who have lower severity, for example, in asthma, do children who have lower severity using that condition-specific questionnaire response, so children who have lower severity based on the PEDS-QL asthma module, do they report different health-related quality of life compared to children who have more severe? So we would expect that differences in that total or level sum score for children who are more severe compared to children who are less severe. And what we see is that for using that based on the condition-specific instrument responses, all of the generic instruments were able to differentiate between that less severe children and more severe children. And really mostly with large effect sizes, but a few with moderate effect sizes. And then the last known group we looked at was, we collaborated with some clinicians when we were designing the survey, and they, for each of the conditions, helped us come up with a few indicator questions for what they might consider severe or not. So, for example, in the epilepsy sample, we asked them how frequently they had seizures and if they were on medication. And so for the epilepsy sample, we looked at children who were more severe based on having more seizures or more frequent seizures. For the sleep problems, it was their parents rating the child's sleep problem as moderate or severe. And for asthma, it was based on having previous hospital or emergency department admissions. So the instruments, this is where they struggle to differentiate between, I guess, those known groups of less severe versus more severe using those sort of indicator questions. So for the epilepsy, the CHU9D wasn't able to differentiate between those known groups, and the EQ-HWB 3L for the sleep problems cohort. And although the other instruments were able to detect a difference, the effect sizes were still quite small. So yeah, it's quite a bit trickier, I guess, in that cohort. But in summary, most of the instruments are doing, I guess, quite well, but for some of the different conditions, different instruments might be more appropriate. So for epilepsy, for example, the 3L, the 5L and the CHU9D perform the best. For the sleep problems, it's the PEDS-QL, the EQ-HWB 5L and the CHU9D. And then for the asthma, it's really the CHU9D. So, things to consider.
Yep, thank you. So the next question we're going to briefly show you is just the performance of the instruments in the young children. So here we have a few measures, and a few of them are quite experimental still, so it's quite new research. We've got a version of the EQ-HWB which was adapted specifically for 2 to 4 year olds. So it's very similar to the EQ-HWB, but the examples are just modified a little bit. We've got the EQ tips, which Janine's been working on developing, the CHU9D and the HWB. And so here we've got children aged 2 to 4, and it's important to note that that matches the age range of all of the instruments except the tips. So the tips is designed to go younger than this. So this is just a subsection of the ages that the tips is suitable for. The other measures, though, are indicated for 2 to 4. And we've got 800 kids in this analysis. So this is just the demographics. So we've got slightly more children who were 4. We've got around a third with special healthcare needs, 37% with a disability. And still, even though most are still reporting excellent or very good health, even though even in hospital samples and so on, it's hard to find children that are very, very unwell. So this is just the raw responses on the instrument. So they can have an answer of 1, which is no problems, the dark blue. This is must be the 3. This is the tips, yes. Yeah. So it just shows you the raw results in the total sample on the left, and then just for those who are reporting fair or poor health on the right. So what we want to see is, I guess, that the distribution's reaching down, that we're getting more kids who are reporting problems. So more kids in these grey and orange bars, which is exactly just when we descriptively look at the data, what we see. And you can sort of see which items on the instrument we're able to pick up more problems in, and we're getting more problems in eating, social interaction and pain. Is where the instrument's really picking up quite a lot more problems compared to the total sample. The next one's the same again, but for this adapted version of the EQ-HWB. So in the same way, the darker blue and green bars are where it's being reported that the children have more problems. So compared to the total sample, the sample who have more needs would expect to see the bars sort of reaching down. So here we get more movement on these looking after themselves usual activities and worried, sad or unhappy through in this group that have the special healthcare needs. But I think the descriptives are all looking like a good direction of what we'd like to see, which is that there's more problems in the children that have more needs. And then this one here is the CHU9D. So the colours are changed, apologies for that, but here it's the red and the orange, that we want to see more of that red and orange in the kids that have fair or poorer health compared to good health. So here, that schoolwork, homework one, and it's modified in the CHU9D. So it's sort of like, it's not just school and homework, it's also their, might be early childhood education or the things they're doing in place of school or homework. And also their usual activities are 2 of the ones that are really moving quite a lot more. But I think you see the idea that once we move from good health to poor health, they're picking up more problems. So that's sort of the first test, just visually. Next, we look at the known group validity. Now, this is quite experimental in a lot of these instruments, so they're very new results. But what we see here is if it's green, that means that we're able to pick up the difference in that group of children with a large effect size. The yellow is a medium effect size and the red's a small effect size. So we've got large effect sizes for most of these instruments. They're looking at between special healthcare needs and no special healthcare needs, having poor or fair health compared to good, very good or excellent. And then the visual analog scale of the EQ, just splitting the sample there. So the ones that the Huey struggles a bit more with only medium effect sizes, but most of these instruments are able to discriminate known groups, which is, I think, a really good start. The next one is responsiveness, and these are also quite early results, so they are subject to still changing. But here we've got those children who are improving their health, the children whose health is staying relatively the same, and the children whose health is worsening. Now, if we think about how we would usually use an instrument in children, we're more so wanting to find the children who improve health. And it's much fewer children that are worsening their health. So I think we could probably focus on the left-hand side as being the most important. Here, we're in small effect sizes for everything. So we've got limited ability to really be able to detect those children who are improving or worsening. The ones that are doing, I mean, there's a few that do slightly better, but we do have small samples. The PEDS-QL, the adapted EQ-5DY, 5L, the CHU9D, they're hitting small effect sizes. The Huey actually hits a moderate effect size, but only in worsening. So this is where the instruments start, it's hard to generate good quality evidence because we're not giving the children an intervention other than what's naturally happening. But we're also into small samples when we're children don't worsen and improve that much over 4 weeks. So it's some preliminary results though. And then we're going to end with parents.
Yes. So as Kim mentioned earlier, the EQ-HWB-S, which just stands for the shortened version. So this is the 9-item version. I can't remember how many items is in the full bank. But yeah, so we were really interested in measuring how this instrument performs in the cohort of parents who completed it. And interestingly, that the EQ-HWB-S was put into the Pediatric Multi-Instrument Comparison Study Survey following some feedback from our consumer advisory group, who thought it would be really important to consider the parent and caregiver's quality of life alongside the child's quality of life as well. So, so we included the EQ-HWB-S and the results here look at the 6,257 parents of children aged 2 to 18 in the study. And very new results, so we'll look at the response distribution by item and some known group validity. So what you can see here is firstly the distribution of responses for the EQ-HWB-S items in parents of children who were from the general population sample, so parents of children who were generally quite well. And then you can see here the distribution for the parents of children who come from one of those health condition samples. So what we see here is some movement on some of the items between the Gen Pop and the health condition sample, really at that more extreme level, so that dark grey level, the level 5. So particularly for exhaustion, highlight that there. So we can see a lot more parents feeling exhausted in that sample of parents of children who have health conditions. Then we had a look at the EQ-HWB-S scores between parents of a child with a health condition and the general population. So again, what you can see there is just kind of nicely overall that parents of children who have a health condition are reporting worse on the instrument than parents of children from the general population sample. Yeah. A little bit less on the mobility, sorry, I should point that out. But we see a lot more differences in some of these other items, but I think it would make a lot of sense that the mobility item sees a lot less of that. Finally, we had a look at known group validity. So we had a look at the difference between parents of children who have a special healthcare need versus not, and parents of children who have a chronic health condition versus not. And what we found was that the both in the preference weighted, so using the utility and the level sum score, the EQ-HWB-S was able to differentiate between those groups with a moderate effect size, which is really quite interesting because I think in terms of care or quality of life, this would be one of the first studies to look at the EQ-HWB-S in parent caregivers. So largely the research sits around carers of people with cancer or older people, and probably was designed for sort of carers of older people or people with dementia or cancer. So really interesting to see that it's working well in parent carers too. So I'll hand back over to Kim.
So we've got lots of follow-up work there because in an economic evaluation, people wouldn't use that yet, right? Like there's a lot to sort out methodologically if we're doing a child health intervention in terms of should we be using the parent's quality of life as well in that economic evaluation? Are we double counting if we're also using cost? Does that matter? Are they weighted the same in terms of public preferences for a child's quality of life versus a carer's quality of life? So there's quite a lot to work out around what we might do with that carer quality of life information. So just in wrap up, this is the first study that's concurrently collected evidence from that same cohort of patients using all of those instruments head to head. So we think it's making substantial new contributions to the research space and filling some of the research gaps. We hope that it will be used to inform the choice of instrument. And you can see there's some instruments that perform quite well across most of the analyses. And there's some where they have a strength for a particular condition or a particular use. So we're really hoping to be able to help people make good choices about what instruments to use in their studies or to use in their economic evaluations. And we hope ultimately that it will help improve the quality of the decision making made for interventions for children. In terms of the overall recommendations, this is just a summary slide of the instruments that we think perform better around those 4 questions that we asked and presented to you today. So it's good that in some ways there's often more than one instrument that is performing well, which I think is good news. And you can see some common threads across the questions in terms of instruments that pop up again and again as doing quite well. So next steps, we need to analyse the extra conditions. So we've only shown you 3, so we've got another handful to go. We know that we need to do some more around responsiveness. We have a sample of children that have the most severe conditions, so we're going to have a particular look at those and see how the instruments are performing. Renee's PhD is going to move into looking at trialling the EQ-HWB in a clinical context, so how we could use quality of life and utility information to improve the quality of the clinical encounter. And also, I guess as health economists, there's a lot of value to thinking about what if we could collect some of this information more routinely, and what extra types of questions and value could we add to health services that we're able to collect it routinely. So Renee's going to be conducting a trial trying to get that to work in our children's hospital in Melbourne. And I guess it naturally moves us then into the valuation space. Once we're able to measure this quality of life, how do we value it in children? Particularly in the young child space, there's a lot of work that needs to be done around how do we do that appropriately. Some of the methods we use for adults don't work so well, and we have more trouble with things like anchoring. We need to solve some of the bigger questions, such as consistency across age. So I think, like, what if I had a vaccine and we give the vaccine and it prevents a disease, but we could be preventing that disease starting as a newborn, moving into childhood, adulthood. If we had the one model that's preventing an infectious disease across the spectrum of ages, how do we deal with the consistency of this? What if we're actually not measuring the same thing across different ages, or what if we're valuing them differently across different ages? Then what are the implications for our model? It might reflect public preferences, but we also might be introducing methodological variation that is compromising our ability to reflect all those health states across a life course. So that's just some big questions that we need to solve and think further about. We're interested to think a little bit more about these parents and carers and spillovers. How do we take this information and appropriately incorporate it in economic evaluations? And obviously we've started with one country here where we're developing up a protocol where we might replicate some of this core work into other contexts, add some extra value-added questions, and see if we can replicate some of this work around the world. So very happy to continue conversations. We've got a Twitter that you're welcome to follow, and we've given you a few links. We're happy to leave the presentation, but we'd love to hear any comments, questions, reflections. But thanks so much for having us along to your seminar.
Well, thank you for presenting and sharing the methods and some of the results with us today. So it's been really a great pleasure, and thank you for organising this for us, Janine. So we'll open the floor for questions. If I could start with a question, maybe it's directed to Janine. It has to do with the threshold. So as we know, thresholds could be arbitrary. So how did you come up with 15%, or should I ask you, because I mentioned your name in helping.
Oh, she had to read the protocol for us, yeah.
So why 15%, and could it be lower or higher? Or how important is it in your study?
Yeah, off you go.
Okay. We spent a lot of time umming and ahhing over the different thresholds, not just for ceiling effects, but for all the other tests. It took up a lot of my life. But with ceiling effects threshold, I think in general ceiling effects is something that I think people are probably less concerned about if the instrument is still able to differentiate between different groups of health-related quality of life, because I guess the concern is that everyone will bunch up towards one end and then you won't be able to differentiate between different groups of children who you think actually have different health-related quality of life or different health-related quality of life over time. And so 15% we landed on, one, because it had been used previously in the literature, so it would be comparable to other outputs. And secondly, that it gave the instruments a little bit of room for error. So, or not error, but you know, if children with chronic health conditions did have no problems, then it gave them some space to sit under that 15% threshold. But over the 15% threshold, we thought might start to compromise that ability to differentiate between groups, although it still is, as you know, with a lot of thresholds, if you sit at 16% or 14.8%, you know, does it really drastically change? And so I think then it becomes important to think that next step of, okay, well, we're concerned if it sits over that threshold that it might compromise its ability to differentiate, and so let's make sure we look at, is it able to differentiate or not?
And it's a bigger issue if the sample's sicker, right? Because if we're seeing large amounts of the sample saying they've got no problems in a sample who we know are really sick, it's a bigger issue than if it's a general population. We've got an online question that's related. Could you confirm the time frame for all instruments is the same? Ceiling effects would presumably be higher if the time frame was shorter, 1 day compared to longer, like a week. Thank you. So did you want to clarify that one?
Yeah, it's a really good point. And so the PEDS-QL asks over a month, and I'm testing my memory a bit here, but I think all of the other instruments ask about today. I think it also impacts the instrument more if it has less items because there's less room for movement. Yeah. So, you know, the PEDS-QL has 23 items where you might be able to move on, whereas, you know, something like the EQ-HWB, you might not. So, yeah, definitely I agree. I think the number of instrument items and the recall period really could impact an instrument's ability to perform well on that.
Great. Do you want to go up the back first?
We're good.
Oh, sorry, you go first.
Thanks. I was really interested to see the difference in performance between males and female children with mental health conditions. Do you have any thoughts on what could be causing that in the instrument or in the population that you?
Yeah, there's a lot that happens by gender in the mental health samples. So you see that difference between externalizing and internalizing problems to begin with males having more of the externalizing problems and females the internalizing. And I think they present differently in society, an externalizing versus an internalizing. And I guess some of the messaging about themselves and how much of a problem they have can be different then between whether it's internalizing or externalizing. So I think there is, and underlying as well across adolescence, we see sex differences just in population norms across girls and boys. Girls dip more in mental health quality of life across adolescence. So, yeah, I think there's some known things happening with gender that could be related to what's happening there. Yeah. Yeah, up the back.
Thank you. I mean, it really was very inspiring to see what research you've been doing and to see the wealth of data that you're able to collect. And we wish that we could do some of the things. But my question is about your current HDA in Australia and what is currently used, what kind of population valuation you currently have, and where you would see this moving going forward.
Yeah, so in Australia, the main place with health technology assessment is in the medicines and vaccines, and that's all based on industry submissions. So if someone wants their drug or vaccine listed, they have to submit as a company. And they have complete free reign of what they use in terms of quality of life. And then the government assembles academic groups mainly who critique that work. So the quality of life measures would get critiqued. And I guess it would be whether it was an appropriate measure, whether it was scored appropriately, whether it was measuring the right population who were matched to that economic evaluation health state. So I think we see a wide variety of practices. but we do have quite a strong critique mechanism that kind of, we lean a lot towards transparency, so not dictating what comes into HTA, but providing transparent information for the decision makers to use it. But we do see a little bit in medical devices and technologies, but we wouldn't have near as much for children. Mostly we'd see children popping up through the medicines and vaccines. Yeah. We have one more question on here. This is Jennifer, did you compare the time taken to fill in the questionnaires? This might be a factor in routine data collection in busy clinics. Do you want to answer that one?
Yes, yeah, we did. Yeah, we could, through the online, we collected data through RedCap. So in the background, we could measure how many seconds they had the instrument open for. Across the main instruments, I think it's test right, but they all took less than sort of 2 or 3 minutes, even the PEDQL, which had 23 items. So they were all relatively quick, but something like the EQ-HWB 3L or 5L was taking, and the EQ chips I think was taking people more like 30 seconds. So, really quick.
And quicker than what the instrument developers say. So we compared like the websites when people said, how long would this instrument take? They beat those scores. They nearly halve them. They really can go quite quickly through them. So, yeah, I think it means there's a few good contenders for clinical practice, and that's the advantage of our generic measures in health economics, I think, is because compared to these pages they sometimes have of the condition-specific measures, our measures are very snappy. And the big thing the clinicians want to know is, do they work for their conditions? So I guess we're hoping some of this evidence can help them see, look, it's short, it's generic, but we're still picking up important differences across health states. So that's the challenge.
Yeah, and one other thing we found when we were looking at the time to complete, Jennifer, to your point on, would it be, how might it be useful in clinical care, was that everyone got quicker for the follow-up survey. Yeah. So I guess that gave us a bit of, we don't have much information about how it might go in clinical care, but it gave us a bit of confidence that if you're asking people in a clinical context to do it again and again, that they sort of, they get better at it and they get quicker at it and they find it easier to do.
And the kids were pretty quick too.
Yeah.
So the kids, I don't think it's that they're not doing it properly, but I think they don't overthink it. Like, as an adult, you're like, oh, well, is it good or very good? Or, you kind of second guess your answer. The kids just go a lot more like intuitive, like boom, boom, boom. So the kids were quite quick when they completed it too. Yeah.
So possible questions. So you said this is the first study of this nature in the world?
Well, there's been studies that have collected data on instruments before, and they might sometimes put like 2 head-to-head, or it might be for a condition. But I think this is the first of this scale that's really putting all of those head-to-head and trying comprehensively to measure right across age and across quite a lot of conditions. Yeah. So there's systematic reviews that show the psychometric performance just from quite a lot of individual studies. And so I guess there's 2 good systematic reviews, one by Donna Rowan, pharmacoeconomics, and one just by Kwon, right? Joseph Kwon. Is that pharmacoeconomics as well?
No.
Value in health.
Yeah, sorry.
So there's 2 systematic reviews that review all of the individual studies that have just looked performance of 1 measure or 2 measures or just 1 condition. So if you had a particular condition in mind, you're probably best to check the 2 systematic reviews as well and see if your condition has some evidence in those reviews.
Yeah. We tried to pick conditions that hadn't already been
covered through the reviews.
Yeah, so there was a lot on cancer, and so we kind of avoided.
And a lot on obesity.
Yeah.
And some of the infectious diseases are quite well covered through the systematic reviews. So we tried to not double up too much with things that have been looked at already.
Mental health, I would imagine, would be a very difficult condition to look at. And you mentioned there were issues there too.
Yeah.
Because difficulties of follow-up, I suppose, too.
Yeah, we got pretty high follow-up in most of our samples, didn't we? Yeah. We were sort of like, our hospital sample, we were sitting at like 85% follow-up. The online dropped a bit more to half, kind of. Yeah. And I think we were relying on the parents to make the judgment about, it's not just based on age, but is your child able to complete this measure? And I guess if they're in hospital with a mental health condition, we were relying on the parent to make that decision about whether the child could complete it right now or whether they needed to report as a proxy. So
Wonderful. Any more questions? Maybe just online check-in?
No, I think we've got them on. Yep.
Well, thank you very much for attending, and thank you. Really, really appreciate your time and your interest in coming to present to us. And we look forward to seeing you here. I know you're here for that reason. So we're going to be seeing them there. And yeah, so please stay in touch via Janine or directly.
And we'd love to hear from any of you too. So thanks for having us.
Yes, we haven't done much work, if any, in this area. But yeah, please stay in touch and good luck with your PhD in particular and good luck with your project. And I hope it becomes used routinely once you find
that'll be the nice part, won't it, to see if it actually can be helpful. Yeah.
Great. Well, thank you very much.
No worries.
Thank you.